Hello, and welcome to the second episode of Practice Pearls Podcast, an educational podcast about menopause for clinicians in primary care and OBGYN.
I'm Amanda Clark, urogynecologist and menopause physician.
And I'm Kim Vesco, an obstetrician gynecologist. Our colleague, Tovi Anderson, will rejoin us for episode 3.
First, a quick review of episode 1. We discussed the SWAN study findings that many women have prolonged and bothersome hot flashes during their menopause transition. And we said that hormone therapy provides the most effective relief of hot flashes.
And we discussed the newest clinical guidelines, which state that menopausal symptoms can be safely treated with hormones if therapy is started near the time of the menopause transition.
Today, we will talk about the risks and benefits of hormone therapy, the evidence we use when counseling our patients about hormone therapy.
There are 2 important studies that primarily inform our counseling. The first is the Women's Health Initiative, also known as the WHI, and the ELITE trial. ELITE stands for Early versus Late Intervention Trial with Estradiol.
Women of menopausal age, as well as older clinicians such as myself, have witnessed the highly publicized swings in recommendations about hormone therapy that occurred during the last 30 years. Today, we will review a bit of this history and explain the rationale behind the changing recommendations.
This episode focuses on the evidence that underlies the guidelines, and it makes it a bit long and heavy compared to case discussions. We hope you'll stick with us.
Estrogen has been available since the 1940s, and it has always elicited strong opinions. In the 1960s, estrogen therapy was touted as anti-aging in a book named Feminine Forever. It was written by an OBGYN physician who labeled estrogen an elixir for life.
In the 1970s, a women's health movement advocated for increased education so that women could have greater control of healthcare decisions. Detractors of hormone therapy argued that doctors were inappropriately medicalizing menopause, interfering with what should be a normal reproductive life event.
Estrogen has always been a controversial topic.
Yes, indeed. In 1975, the controversy took a scary turn when estrogen was linked to cancer. Headlines proclaimed that estrogen use was linked to a 14-fold increase in the risk of endometrial cancer.
It's important to point out at that time, estrogen was given alone. We now know that adding a progestogen, that is progesterone or a synthetic analog of progesterone, for women with an intact uterus reduces this risk back to baseline.
With the fear of endometrial cancer being addressed by the addition of a progestogen, hormone therapy continued to be recommended for menopausal symptoms.
Attention then focused on estrogen's effect on chronic disease. We knew that osteoporosis was more common in older women and that heart disease was more common in older men. Estrogen seemed to have a role in both diseases.
One of the first important trials in 1996 was the postmenopausal estrogen-progestin interventions trial, often referred to as the PEPI trial, which showed that hormone therapy could actually improve bone mineral density in postmenopausal women.
At that time, we could only speculate that improved bone mineral density would translate into reduced fracture risk. Showing this would take a much bigger and longer trial. And sneak preview, the WHI did prove that this was true. More on this later.
And then there's heart disease. Early observational trials suggested that estrogen had a protective effect. In 1992, a meta-analysis of many observational studies suggested estrogen therapy might confer a 50% reduction in the risk of heart disease. Many experts advocated estrogen for all postmenopausal women to promote heart health. Along with the potential benefits of estrogen for the heart and bones, there were worries. Oral contraceptive use had been linked to increased venous thromboembolism, and several observational studies reported links between estrogen and breast cancer.
But we know that observational studies don't prove causation. Perhaps women who chose to take estrogen were also healthier women who just received more mammograms, and these factors accounted for the differences. Addressing these questions led to the largest clinical trial ever undertaken at the time, the WHI.
So it's very important to discuss the Women's Health Initiative because it had such an impact on our practice today. The WHI was a very complex trial with several goals. For these podcasts, we'll focus on the randomized clinical trial of hormone use. That trial enrolled 27,000 postmenopausal women who ranged in age from 50 to 79, and the goal of the trial was to evaluate effects of hormone therapy on common chronic diseases of aging.
Within the hormone trial of the WHI, there were two arms. Women with an intact uterus were randomized to receive an estrogen plus a progestin or to placebo. Women who had undergone a hysterectomy were randomized to estrogen alone or placebo.
And speaking of a long trial, the planned follow-up time was 9 years.
27,000 women followed for 9 years. That is a very big study.
A study of this magnitude was required to evaluate the primary outcome of coronary heart disease and the primary safety outcome of breast cancer. Several acute and chronic diseases were evaluated as secondary outcomes.
It's important to note that the average age of the participants was 63, well past the age of the menopause transition. The first report of the WHI came out in 2002, and it was almost heart-stopping. Instead of showing the expected 50% reduction in heart disease, there was actually a slight increase in heart disease risk for women taking estrogen and a progestin.
There was also a small increase in risk for breast cancer and stroke. In contrast, there were decreases in risk for colon cancer, osteoporosis, and fractures. The balance of risk and benefit was judged to be more on the risk side, and the estrogen plus progestin arm of the trial was terminated after only 6 years.
All primary care and OBGYN clinicians in practice in the year 2002 remember this first report from the WHI like a bomb dropping. The news media proclaimed the dangers of hormone therapy, and our offices were inundated with phone calls from anxious women.
That's right. Our entire practice related to hormone therapy was completely upended after that day. The medical community stopped touting the benefits of estrogen for heart health and instead reserved hormone therapy as a last resort for menopause symptoms.
We had a lot of miserable women, and we had little to offer them. The mantra after this report then changed to what we've known for so many years, that is to use the lowest dose for the least amount of time possible and for no longer than 5 years.
Unfortunately, the headlines at this time missed several nuances about the WHI findings. First, the estrogen-only arm didn't show the same results. Women in this arm never showed an increase in heart disease, and the risk of breast cancer was actually reduced. The estrogen alone arm was later terminated early, after 7 years, but that was due to a small increased risk of stroke.
5 years after the initial WHI report, in 2007, the findings were analyzed and reported by age group, and this showed something very different for women in their 50s compared to the older women. In the estrogen alone and in the estrogen plus progestin arms, there were actually lower rates of heart disease compared to placebo, even though in the overall study the rates were higher.
The evidence from the subgroup analysis wasn't strong enough to justify a change in recommendations, but it did lead to the development of the timing hypothesis.
You'll be hearing a lot from us about the timing hypothesis.
This hypothesis suggests that the risk-benefit balance for hormone therapy may differ when it's initiated closer to the onset of the final menstrual period, rather than many years after the onset of menopause.
We now have evidence to support a cardioprotective effect for women who start estrogen close to the time of the menopause transition. This evidence comes from the ELITE trial, the early versus late intervention trial with estradiol. To remember ELITE, think early versus late.
The ELITE trial compared hormone therapy that was given within 6 years of a woman's final menstrual period to hormone therapy given 10 or more years after the final menstrual period. Women with an intact uterus were given estradiol plus progesterone, and women without a uterus were given estradiol alone.
Both the early and late arms of the trial had a placebo group. The primary outcome was progression of atherosclerosis, monitored by ultrasound in the carotid artery. They measured the thickness of the intima media layer during the 5-year follow-up.
And using these measurements, they found that all women experienced progression of atherosclerosis, but for women in the early treatment arm, the amount of progression was about half that of the placebo group. Women in the late treatment group did not show any difference in progression from those in the placebo group.
The findings of the ELITE trial match findings from animal studies and provide an explanation for the positive findings in the observational studies. Those observational studies weren't wrong. They just measured the effects of giving estrogen therapy to younger menopausal women.
The WHI findings were also correct for older menopausal women. Giving estrogen to women late, 10 years after the menopause transition, is not cardioprotective. In older women with established atherosclerosis, we think that estrogen's effects lead to more cardiac events.
Clinically, these results translate into the recommendation against prescribing estrogen to older women as a strategy for preventing chronic diseases. This fits with the U.S. Preventive Services Task Force recommendations against hormone therapy for prevention of chronic disease.
For younger women, these results translate into the new recommendation that when estrogen is given early, near the onset of the menopause transition, it is cardioprotective and thus may be safely prescribed to treat menopausal symptoms.
Heart disease was the focus of the WHI, but it looked at a number of other diseases. We'll briefly touch on the major findings. I warn you that it is a big list. We'll provide details in the references.
First, let's talk about breast cancer. In my experience, the risk of breast cancer is often the first concern that comes to mind for women when considering hormone therapy.
Our strongest evidence comes from the randomized trial of the WHI. Women in the estrogen plus progestin group experienced a very small increase in risk, 1 case of breast cancer per 1,000 women years of use. In contrast, women in the estrogen alone group had no increase in risk.
And although that attributable risk of breast cancer due to hormone therapy is very small, many women find it difficult to accept any increased risk of cancer. For many women, anxiety about breast cancer often seems to be a major factor in the decision for or against hormone therapy.
Does your recommendation change if there's a family history of breast cancer?
Limited evidence suggests that there's no increased risk of breast cancer with hormone therapy use when there's a family history of breast cancer or genetic susceptibility for breast cancer, although anxiety about breast cancer is often higher for these women.
There is a positive note for another common cancer. Estrogen plus progestin therapy reduced the risk of colon cancer in the WHI cohort. So now to osteoporosis and fracture prevention. From the SWAN study, we know that the menopause transition is a time of rapid bone loss in women. There's an abrupt drop in bone density that begins 1 year before and continues for 2 years after the final menstrual period.
The WHI showed that hormone therapy does prevent fractures as well as preventing bone loss. Advancing age is one of the strongest risk factors for fracture, and for most perimenopausal women, the risk of fracture is low. However, the positive effect on bone is another benefit to consider overall.
Please note that the positive effects of estrogen on bone occur only during treatment, and these effects diminish rapidly when estrogen is discontinued. Perimenopausal estrogen use doesn't reduce fracture risk later in life unless it is followed by other osteoporosis treatment.
Another important outcome studied in the WHI is the risk of stroke. In brief, there is a very small increased risk of stroke with oral hormone therapy, but the risk of stroke in women under 60 is very small to begin with. Clinically, a very small increase in a very small risk adds up to a very small absolute risk of stroke in younger women.
The WHI studied venous thromboembolism and found that its risk is increased by hormone therapy, even with early initiation of therapy in younger women. But as we said with stroke, the baseline risk of venous thromboembolism for most perimenopausal women is quite low to begin with. So as Kim said, a small increase in a small risk translates to very few clinical events.
In the WHI, they used an oral estrogen, which is highly metabolized in the liver, leading to increased production of coagulation factors. Since the WHI, large observational studies have suggested that estrogen therapy through a patch, or transdermal estrogen therapy, may lessen the risk of stroke and venous thrombosis by avoiding this hepatic first-pass effect.
Now to dementia, which was also studied in the WHI. We learned that starting estrogen plus progestin after age 65 is associated with worsening memory and that the risk of dementia was doubled compared to placebo. In the estrogen alone group, there was no increase in dementia.
For Alzheimer's disease, observational trials suggest a similar timing hypothesis with early therapy associated with prevention. However, no randomized controlled trials have been completed to confirm this hypothesis.
Back to the WHI. The investigators also examined the effects of hormone therapy on body composition and metabolism. During the first year of the WHI, women using combined hormone therapy experienced a small decrease in body mass index and waist circumference. Now considering diabetes, there was a 19% reduction in the incidence of type 2 diabetes in the estrogen plus progestin arm. Similarly, there was a 14% reduction in the estrogen alone arm. This fits with meta-analyses that show a 40% reduction in fasting blood glucose levels and hemoglobin A1C for women on combination therapy.
Another benefit of hormone therapy that impacts women's quality of life is a reduction in joint pain and stiffness. But another downside relates to gallbladder disease. The WHI demonstrated that women using oral hormone therapy have a greater risk of gallbladder disease. Observational studies suggest that transdermal estrogen may mitigate this risk.
Weighing this long list of benefits and risks is challenging for clinicians and I think even more so for patients. Looking at overall mortality associated with hormone use is a way to integrate all of this information.
And here we have reassuring news. The investigators of the Women's Health Initiative were concerned that hormone therapy might be associated with an increase in all-cause mortality. But 18 years after the study's inception, the investigators found that there was no increase in all-cause mortality associated with estrogen plus progestin therapy or estrogen therapy alone.
To restate what you just said, the WHI found that using hormone therapy for 5 to 7 years did not lead to premature death, nor did it increase longevity. So the overall effect on women's health is neutral.
If a woman's menopausal symptoms and quality of life are improved by hormone therapy, the balance of benefit to risk favors hormone therapy.
Thank you for staying the course today. We've quickly touched on the major risks and benefits that you'll discuss when counseling your patients about hormone therapy. Please check the Practice Pearls podcast website for links to these landmark studies.
In the next episode, we'll talk about how to prescribe hormone therapy.
And we'll talk about the marketing and mismarketing of bioidentical hormones. We'll clarify the facts and debunk a lot of the fiction. This is Amanda Clark
and Kim Vesco.
Thank you for listening to Practice Pearls podcast, Menopause.
All cases appearing in this work were developed to highlight common clinical scenarios. Any resemblance to real persons, living or dead, is purely coincidental.